All righty, welcome. We had a bit of technical difficulties this morning from our lovely presenter, Dr. Agu. He was on board just a few minutes ago. However, we do have Dr. Pekia here today, who is going to start us off with the presentation in the meantime, and then hopefully we will transfer back over to Dr. Agu when he comes on board. But just to be cognizant of time, I think we're going to go ahead and get started.
All right. Welcome everyone to Global Ground Rounds. As you know, most of you know, this medical education division of Global Offsite Care, and this is the presentation anticipated, and hopefully we'll see our speaker be able to log back on soon, of Dr. Anele Agu. I'll go ahead and present his bio, and assuming that he'll be coming on soon after we start moving through his PowerPoint, then we'll then take some questions intermittently through the presentation, and I welcome your feedback. Feel free to stop me, interrupt, to share some perspective and any questions or comments you might have. So Dr. Agu's work as a consultant plastic surgeon takes place at King Khalid Hospital, Saudi Arabia. Actually is a consultant there, as a former lecturer the Niger Delta University in Nigeria, the consulting plastic surgeon, also at Federal Medical Center at Yanagawa, Nigeria, the ABIA State University Teaching Hospital in Nigeria, the founder of the Agu Specialist Hospital, Aba, Nigeria, and the former chief executive ABIA State Hospitals Management Board in Nigeria. He's been a doctor since June of 1985, and a consulting plastic surgeon from April 2008 until the present. So welcome, Dr. Agu, when we can see you back coming in.
He is here. We have him here.
Yes, I'm here. I'm back. Yes, I'm back.
Perfect timing. All right. Dr. Agu, I just completed your the introduction of your background and experience. So welcome back, and thank you so much for joining us today to present on this important topic. So the floor is yours.
Yeah, thank you very much. Thank you. Today we want to talk about bonds, and bonds is a topical issue at any point in time, and it is my pleasure really to talk about resuscitation of bonds. But as you all know, bonds is a very wide topic to discuss, and I just have about 45 minutes to do the discussion, and I will go to the salient things, these things that are really important in this discussion. Yes. Yeah, I will use this outline. I introduce and talk about the anatomy, and then talk about the pathology, and then summarize and conclude. Burns is a coagulative necrosis or liquefaction necrosis, depending on the cause of the burns. If it is thermal or acid, it will cause coagulative necrosis. But if it is alkali, it will cause liquefaction necrosis. And usually the necrotic area is defined by Jackson zones as the center and the center of necrosis. Then next to that center of necrosis, you have the center, the stasis, the zone of stasis, and then the zone of hyperemia. Bonds, I always say that bonds is always a winner because once bonds occurs on any part of the skin, it leaves a mark, and that mark remains. is still rampant from kerosene explosions in Nigeria, storing of petrol in homes, poor knowledge of safety measures, non-existent fire brigade, poor knowledge of first aid measures. Then habits in those who drink tea and walk along with the tea. I know some cultures do that. So burns, especially scars, are also rampant. Then chemical burns are actually more common in advanced industrialized nations. Then occasionally we have violence, people that are violent prone, assault, they assault people with acids and alkali. We'll talk briefly about the anatomy of the skin. We have the epidermis, which is multi-layered, the dermis, then the subcutaneous tissue, which is really not part of the skin. The epidermis is also multi-layered. The dermis contains the subdermal plexuses and contains all the organelles like the hair follicles, sebaceous glands, sweat glands, blood vessels, and the collagen and elastic tissue. Then this is a diagram showing the skin. You can see the hair follicles. You can see the sebaceous glands, the erector pili muscles, then the blood vessels that are located within the subcutaneous tissue, and then the sebaceous glands and the sweat glands. Then we also cannot talk about burns without knowing the degree of burns. We have the first degree burns, which involves only the epidermis, difficult to see in the dark skinned people, but in white skin it forms as erythema or just as suntan. No blisters and no treatment is required. The second degree, various levels of burning of the dermis, red, pink, blotchy, white, painful, intact sensation, and using of serum. And there may be no blisters or no blisters, depending on the depth of the second degree. Capillary refill can also be brisk or sluggish. Then the third degree burns, there's a complete loss of the dermis, and there's therefore complete loss of sensation, no blisters, absent capillary refill. And then the fourth degree burns is described in the US. In Nigeria, we rarely talk about the fourth degree. People even talk about the fifth degree and the sixth degree. And the sixth degree, which has been propounded, the fifth degree is when the muscles are involved. The sixth degree, when the bone gets to the bone. Then for the first degree burns, which I said is just epidermal burns, you have red, brisk capillary refill. 1 to 2 seconds, the capillary refill back. Then the superficial derma has small blisters, brisk capillary refill, 1 to 2. But the mid-dermal burns are a little sluggish. The capillary refill is a little sluggish, and it's dark pink. The deep dermal burns are red, blotchy. You see some whitish substances at the floor of the burns injury. Then there may be blisters or no blisters. There's definitely sluggish capillary refill. Then in full thickness burns, you have a skin that is looking lifeless, white, brown, charred, no blisters, absent capillary refill. Sorry. Then this is a typical first degree burn, this epidermal burn. You can see this is a fair-skinned young man with burns of the chest. And then this burns, like I told you, does not require any form of treatments. We don't even include it when you are calculating the percentage burns. Then the partial thickness burns, these are pictures of the partial thickness burns. If you look at the diagram from the right of this, you see a burns wound that is reddish. That is a deep dermal burns. And then if you look on the left, you see a pinkish burns wound and a blister. Those ones are the more superficial burns. And like I said before, when you have very superficial second degree burns, they appear as blisters and then pinkish. But when they are deeper, you now have deep dermal burns, which will look reddish with spottings of white on the burns wound background. Yeah, this is another picture, a series of pictures also showing from the right of the screen too, you will notice a lifeless skin. That is a full thickness skin bone, third degree bone. So this involves the whole of the dermis. Then at the middle there, the second one from the right, you will find spotted white. That's the deep dermal bones. Then the next slide also shows a deep bones. Then the more on the left side is also a partial thickness bones. Then, like I mentioned, the pathology of bones injuries have the Jackson zones. This place of the place where you have the necrosis, the center of the bones is the zone of necrosis. Then next to that center of necrosis is the zone of stasis, where you have the clots and the swelling cells that impede blood flow. Then next to that, more peripherally, you have the zone of hyperemia, where you have increased blood flow from inflammation. The principles of bones wound management. You must ensure adequate perfusion, because this is key to the resuscitation of these patients. Then bone is a multidisciplinary management. Once you fail to realize that you want to do everything by yourself, especially in parts of the third world, you find out that you mismanage the bones. This should be emphasized, and there should be a lead. Then you must minimize bacterial contamination. Then minimize negative effects of inflammation. You must modulate inflammation. If not, you will continue to have problems with that bones wound. Then you must provide optimal wound environment. Then you must promote nutrition. These burns cases require adequate nutrition, especially high protein diet. Adequate pain management is also important, because if you're addressing somebody's burns wounds and the person is feeling pain, you may not do a thorough job of that addressing. They must promote re-epithelialization and provide pressure management in cases that require them. Then in the management of burns, we use the Wallace's rule of 9 to calculate the percentage bones surface. The head and neck is 9%, the limbs are 9%, the trunk is 18%, the lower limbs are 18%, then the perineum is 1%. Then for a child of 1 year, you have the head being 18% instead of 9%. And for every year that child adds up to the 10th year, you remove 1% from the head and add half to each of the limbs until the child is about 10 years. But please go back to the slide, please. Okay, there are other things you can use in estimating bones wounds. You can use the Lund and Bruder chart. You can also use the palm of the patient to estimate the bones. Then in the resuscitation of bones, which we are really discussing today, you scoop and run, because if you leave somebody in a burning place, the person will burn to death. But you first of all remove that person from burn, then they apply the necessary first aid, and most of the time the adequate first aid is water, except when you have exothermic chemicals that will increase heat production when you apply water. Otherwise, water is still clean water, 8 to 25 degrees, running water is best. Then you must have an IV access. And if it is necessary, oxygen should be available in that ambulance that came to pick up this patient. They remove all jewelry, remove all dresses. Then you must have ABCD management of any trauma in your mind. History, you do a quick history, a quick examination, place the patient online, and assess degree and body surface area of bones, and you can actually start the resuscitation right there where you came to rescue this patient. Then, like I said before, the bone surface area will usually be calculated for adults with the Wallace's rule of 9, and for the pediatric patients, Lund and Bruder, or like what I mentioned before, you can actually use Wallace's rule of 9, but the modified type for the children. Yeah, that's what I was talking about, Lund and Bruder chart, palm of the patients. When 10% of the patient's body is burnt, especially in children, 50% in adults, and you have inhalational injury, electrical burns, thunder, nuclear, chemical, when flexures are involved, perineum is involved, neck is involved. This will require IV access and admission of the patients for treatment in the hospital. Then in resuscitation, fluid, like I mentioned, is very, very important. Fluid administration, and we use Parkland formula to, Parkland formula says 4 times body surface area burns times the weight of the patient. And this is in meals. And you give half of that meals, which the preference of fluid is Ringer's lactates or normal saline. And you give half of that in the first 8 hours and use the other half in the next 16 hours. And subsequently, you must monitor the urinary output of this patient. 0.5 ml to 1 meal for most superficial burns, therefore 1 to 2 meals in children, and also in acid and other major burns. But in this, you must monitor strict hourly input and output. It's not 24 hours monitor of the burns injury. This is hourly monitor, because the 1 hour that you miss may spell doom for that patient. There are other formula, like I mentioned the Parkland formula, which is 4 times body surface area burns times the weight of the patient. The other formula, Mount Vernon, Collins. And then you must do investigation. The basic investigation, you must do CBC, you must do chemistry. In RVS, depending on the program of the country or the area where grouping and cross-matching may be important, wound swab in contaminated wounds. Other investigations are based on comorbidities and result of secondary survey. Then in that case, you can do ECG, you can do chest X-ray, and for females, especially childbearing age, you need to do the pregnancy test. And then arterial blood gases and carboxyl hemoglobin in those who have inhalational burns. Other necessary investigations, you may need adjunct to the treatment, you may need transfusions. You may also need a tetanus toxoid, depending on the program they have in that country. Then major burns, you will also give these patients to prevent Collins ulcers, which are minute ulcers they find in the stomach, the H2 receptor antagonists, cimetidine or ranitidine, or any other that you have available. Then in the secondary survey, this is when you now do a more detailed probing. By that time, you've stabilized the patient. Then you now do a more detailed probing of this patient. And I have this mnemonic, which is a ample, which you can use. It tells you about the allergies. You find out about allergies, you find out about the medication that the patient is on that may affect your management. You find out about past illnesses, past surgeries, past medical treatments. Then the last meal that this patient has. Then what are the events that this patient has? This patient may have jumped from upstairs, and may have had other environmentally permitted injuries, head injury, or fractures. So you need to use this acronym AMPO to do a secondary survey. Then you also look out for explosions, because burns may also be accompanied by explosions, depending on what is causing the burns. You may have explosions, you may also have exposure to chemical fumes. Then in the resuscitation of this patient, the A, B, C, D, E, F that we usually use in trauma cases is very, very important. The A there is airway, B is breathing, the C is circulation, then D is the disability and the neurological deficits, and then exposure and examination, and then fluids. These are the essential things that you must do. You must make sure that find out whether there's stridor with a pending airway obstruction presenting as well as parasitic cough. Then if you're giving this patient oxygen, it must be humidified oxygen with a flow of 15 liters, 100% oxygen with no rebreathing mask. Sacrificial chest burns may require escharotomy or escharotomy. And then carbon dioxide poisoning will also require attention. Then in inhalational burns. When there is acute edema of the larynx, you may require an intubation. I remember a case that came recently to my hospital here that had major burns. He also jumped down from the story building and injured himself. When he came, he was fully conscious. But even before the head of the team, which is the plastic team, were invited, the anesthetists were already there. They had already intubated the patient before we came. That was why I was emphasizing multidisciplinary treatment for this patient. Then you must elevate the head at 30 degrees inclination or less contraindicated. Carbonaceous sputum, that will tell you of an inhalational component. Then for the circulation and cardiac status, you look at the capillary fill of the limbs, elevate the limbs when there are no signs of compartment syndrome, because if there is a sign of compartment syndrome, you don't need to elevate that limb because you may make the blood supply to that limb more precarious. Then the disability and neurological deficits, you look at Glasgow Coma scales, the pupillary reactions and reflex, the lateralizing signs, exposure, examination with environmental control, remove all jewelry, clothing, keep the patient warm, log row, because there may be other injuries. There may also be a component of a criminal act because some people assault others and they force the person to tell lies when they present to the doctor. Then fluid resuscitation, like in children that are less than 30 kilograms, this line will be added. Then those who have more than 30% or more burns, you need to have 2 IV access. And then you calculate based on the age of the patient, 2 to 4 times body surface area for children. And then for 3rd-degree burns, you can actually use for children 3 ml per kg per body surface area and do your calculation. High voltage electrical burns with evidence of hemachromogen in the urine, red pigments, you may need to increase the figure that you are using in calculating, multiplying the body surface area and the weight. And the preferred fluid is always ringless lactate. Yes, move on. Yeah, disability. I also have this acronym, AFPU, which means alert, focus, stimulant, response, pain response, response to pain, and non-responsive. This will tell you the level of degeneration or the level of depression of the central nervous system. Of course, the eye pupillary reaction and size will also help you. Restlessness could be due to other things apart from head injury. It could be due to drugs or due to hypoxia. And it's just actually necessary in the resuscitation of burns cases. Then what are the criteria for admission? When you have 10% burns in children, body surface area, children less than 2 years, and adults more than 50 years, or children more than 15% in children more than 2 years, and those who are more than less than 50 years. Adults, it's also a criteria. Then if you have deep burns, 5% maybe from acid or electrical also requires admission of that patient. Then if you have 7.5% for an adult with deep burns, something like acid burns, it also requires admission. Then every 3rd-degree burn of any age requires that admit this patient for observation. Then electrical burns, including thunder and chemicals, also require that you admit this patient. Burn injury patient that will require social, emotional, or rehab cares will require to be admitted, no matter the percentage burns. Then inhalational burns, like I mentioned before, special areas like the joints, the face, the perineum, the hands, the neck, and any comorbidity that will complicate treatment of this patient will require admission. For chemicals, for dry chemicals that cause burns, brush off, use brush to brush off the chemicals. Avoid direct contact. If you are rinsing with water, rinse with copious amounts of water and ensure that the water flows away from the patient. Don't use water that is the water in exothermic chemicals like carbide and potassium. Then for the liquid, you flush with copious amount of water. For the eye, if there's an eye contact lens, remove the contact lens, irrigate, and check for corneal lacerations. At this point, actually, you need to involve the ophthalmologist. You have to have an ophthalmologic consult. Then you do your electrolyte and do other blood tests that are necessary. Then for fasciotomy, when you do fasciotomy, it may be indicated, especially in burns of the extremities, to avoid compartment syndrome. A longitudinal incision is made, and which includes the deep fascia, where the circumstances. But if it is just the burns and there is no compartment syndrome within the muscle compartment, then you may just do a fasciotomy and release the fascia so that that person will not have extensive necrosis of that limb. Then for manometer, if you have manometers available, 40 to 50 millimeter mercury in a patient with diastolic pressure of 70. with the 5 Ps, not the 5S, the 5 Ps, the pulselessness, paresthesia, poikilotemia, or those signs of compartment syndrome. Once they are there, you need to do a fasciotomy. Then your finger is also a guide to the tension that is in the tissues. Like we had a case recently, it was the finger, this is because we did not have the manometers around, and it was a finger palpation from experience that made us to take that woman, and we were able to save the limbs. Then elevation, like I said before, you elevate limbs, but if there are signs of compartment syndrome, you don't elevate that because you may make the blood supply to the more precarious. Then for the head and neck distance, unless there are contraindications, you elevate that head at about 30 degrees. Hands are splitted in position function. Then axillaries are also abducted, and then the groins are also abducted. Neck, you only hyperextend the neck. That is enough with a pillow in order to prevent mental stomach contractions. Well, there are other things that help you in managing bone scale. Feeding tubes, when you have to 5% body surface area, you may need a feeding tube. Total parenteral nutrition, you may need albumin. Like I mentioned, escharotomy is also important. Escharectomy is important. And also blood transfusions may be necessary, depending on the percentage of the bones. And I found out that most people that come up with up to 35% bones, most of the time require blood transfusion within the time they're on admission. Pain management. I need to emphasize this because even when you are dressing a wound, if there is pain, you cannot continue with that dressing. You may do a thorough job. And there are NSAIDs, narcotic analgesics, petidins, morphine sulfate, and others, which you can use. Then for the deep bones, if you want to do a tangential excision, if you use copious amount of lignocaine jelly, you can actually do that. But if it is not available, you can go for a general anesthesia because you cannot use a local anesthesia to do a tangential excision. Then oral ketamine has been tried and is still experimental. And in my hospital here, there is also conscious sedation. We had a case like that a young man who had a very low pain threshold, you have to get into some of those these things in order to be able to trust him. We had to take him to the theater a number of times just for dressing. So pain management is quite important. Antibiotics in infected wounds, a lot of things are applied in wounds, especially for those who don't know, they apply all kinds of things. In Nigeria, for example, some people apply cassava water and all kinds of things onto the wound. And these things end up infecting the wounds. And no matter the amount of cleaning that you may do, you may need to give antibiotics, especially when you have these wrong first-aid applications. Tetanus toxoids are also important in the management of this anticoagulant for morbidly obese, non-motivated patients. And you can give any one that is available. Time management of burns. This is an acronym. The T there represents tissue. If there are dead tissues, you debride. For infection, if there are signs of infection or inflammation, you need to weigh the bacterial balance. There are so many things that help us to control infection. Articles, silver cell, bacteriographs, just name it, even silver cell in this place where I am, then you must maintain moisture. That is why closed dressing is preferred to open dressing. Because, like I said, a dried wound is a dead wound. And the epithelial cells that are migrating from the cut, sebaceous gland, hair follicles, will not find a way to migrate if you allow the wound to dry. So you must maintain moisture. That's why closed dressing is more important than open dressing. Then edge of the wound, there are advanced closures. We have BioBrain, we have xenograft, we also have Integra and so on, which are used in covering the wound and reducing the amount of serum that is lost in that wound. Then this application, that's a clean wound on the left of the screen, and there's a article that is being moistened to apply on the wound. If the wound, you find any form of any sign of infection, you can use all this to control infection. It's not every time that you have maybe a little infection of the wound, and then you prescribe antibiotics, take a wound swab. You can actually control these emerging infections with things like Sevacel, Acticoat, and so on. Next slide. Yeah, that this another application. You see the Acticoat has been applied, and you also have additional covering to the Acticoat. You don't leave the Acticoat exposed. You also apply dressings on top of that and secure the application. This is another wound that has been cleaned. Look at on the right side, you have pictographs. After the pictographs, you put another dressing on top. If you have a bounce pack, that's okay. If you don't have a bounce pack, you can use just gauze to dress the wound, or even the mop that we use in general surgery. That's the dressed wound. Next slide. Monitoring of patients. Burns of 10% and 50% insert an indwelling catheter. And especially also, if you have burns of the penis, no matter the degree, no matter the surface area burns, you must insert the catheter when you have burns around the perineum involving the penis. Then 1/2, that's 0.5 ml to, oh my God. Sorry. 0.5 mils to 1 mil per kg per hour is what you are aiming at, like I mentioned before. Therefore, deep burns, you may require 1 to 2 mils per kg per hour. The inhalational burns, monitor the blood gases. Delayed resuscitation, fluid loss prior to burns, like firefighters who eventually get burns injuries. You may need to increase the expectation of urinary output. Electrical burns, like I mentioned before, you increase current fluid if you have less than 0.5 minutes per kg per hour. That's why it is necessary that you monitor the patient hourly. Then you need to increase the fluid intake by 1/3. Then if you have more than 2 ml per kg per hour in superficial burns, you need to decrease the fluid by also 1%. So these are titrations you need to do for these patients. You cannot admit a burn patient and go to sleep. You must monitor closely to make sure that the patient is making adequate urine and the patient is not making too much of urine, because you may be overloading the system, especially children. Don't decrease IV efficiency below the daily fluid maintenance. Then maintain IV until the patient starts taking adequate orals. Next slide. Insert energy tubes and nasogenital tubes in people who have 20% in adults and 50% in children, body surface area, and those who are prone to gastric dilatation and ileus. And also intubated patients and those with associated trauma. You must pass a catheter when you have more than 20% burns injury, especially, and also injury to the genitalia. Monitor the urinary output, like I mentioned before, and then monitor may be necessary. Next slide. Next slide. 20% body surface area, give an IV fluid, like I mentioned before, until adequate oral is established. And depending on the age of the child, 2 to 4 mils, you can multiply with weight and body surface area to get the quantity of fluid you need to get. Greater than 25%, place an enteral tube. Then at 12 hours, I'm talking about pediatric burns now, because the pediatric injuries are more precarious because of the volume, let's say depletion that the children have. And they easily go into the volume deficit. So you need to monitor this patient, monitor the fluid administered. If this patient presented from somewhere and you've calculated the fluid given, and the person is up to 6 ml per kg total body surface, switch to difficult resuscitation. Check sodium and potassium every 12 hours and adjust fluid accordingly. Switch to difficult resuscitation if the total fluid that has been administered on that patient is about 6 ml per kg total times body surface area has been administered. Goal is to revert to less than half of the past 16 hours fluid administration. Next slide. Then greater than 20% burns, start a beta blocker. There are so many of them: propranolol, metoprolol, oxandrolol, which you can give 20 milligrams per, you can give 0.5 0.1 milligram per kg repeated intermittently as required. Urinary output, if it is less than normal, in the first one, increase the fluid by 1/3%, 33%. That's 1/3. Then the 1/3 of what you have calculated. Then if you do it again, increase by another 1/3%. Don't just overload the patient in children, these children. Then on the third attempt, the next third hour, check for Foley's catheter, check for obstruction, and notify the team. This is the time to notify the nephrologist, because you may be having a hypoglycemic status with a hypersmolarity. If nothing is found, then switch to difficult resuscitation. Next slide. Then in difficult resuscitation, we use 5% albumin. You can convert 20% albumin or 25% albumin by adding 1 in 1/3, 1 in 3 of the albumin to 3 parts of normal saline. And then that for 20%, and then for the 25%, you can convert by adding 1 into 4. And then you, depending on the percentage, from 30 to 50, it gives 0.5 ml per kg, and then add it to your requirements for that day. Then check bladder pressure with Foley's catheter technique. If urine is still less than 0.5 ml per kg per hour in a child that is more than 20 kilograms, or less than 1 ml per kg per hour in a child that is equal to or less than 30 kg weight, consider central venous pressure from subclavian or internal jugular. And then you also monitor the central venous saturation. Your goal is to have a central venous pressure of 8 to 10, and a central venous saturation of 60 to 65. Next slide. Then the central venous pressure is still not at goal. Increased by 33%, the fluid increase, fluid absorption by 33%. That's 1/3 of what you calculated. And if the CVP is now at goal, the central venous pressure is now at goal, transfer this patient to the ICU and consider dobutamine. You can also monitor the CVP and the central venous saturation, and if your urinary output is less than target, you are not required at this time. When you have given enough, you stop increasing fluid, because this patient is hemodynamically optimized, and your liguria is established renal insult, which can be tolerated. Because when you increase resuscitation mobility, which is more detrimental than renal failure, which can easily be taken care of by the nephrologist. Next slide. Next slide, next slide. Then when patient becomes hypotensive, we are talking about children now. When patient becomes hypotensive, you may need to switch over to hypotensive guidelines. The individual, these are individualized. The mean arterial blood pressure usually is about 70 to, normal mean arterial is about 70 to 100. If you have a mean arterial blood pressure that is going down and your urinary output and it's inadequate to maintain urinary output, you may need at this point to add vasopressin, continue to monitor central venous pressure, and ensure that this central venous pressure is between 8 to 10. Then if the central venous pressure is not at goal, increase IV fluid by another 30%. Then if CVP is at goal, add norepinephrine. And then you may, at this point, also add hydrocortisone in 2 milligrams per kg per body weight. Next slide. Then a missed injury may be suspected when you have given vasopressin and there is no, you are not making any headway. Then you can use your central venous saturation. This patient may be volume depleted. Note that central venous pressure, when not at goal, increase fluid. CVP at goal, titrate adrenaline. In hypotension cases, look for missed injury and initiate hydrocortisone. This is the summary of what I've just said in pediatric resuscitation, and consider neosynephrine addition as a last result. Next slide, please. When this pediatric patient is exhibiting signs of catecholamine resistant shock, consider missed injury, consider acidemia. Look at the pH, less than 7 point, adjust ventilator to target carbon dioxide pressure of 30 to 50, 35, 30 to 35 millimeter mercury, and considered bicarbonate administration. If acidemia persists, adrenaline insufficiency may also be suspected, then you start an IV hydrocortisone of 2 milligrams per kg every 8 hours. You also look at the calcium level. If it is less than 1.1, you may need to give calcium supplement in form of IV injection. Next slide. So we have been talking about resuscitation of bones, what you do from the site of the injury to what you have to the ER where the patient is now, and then into the ward. So what are the take-home events or take-home, what we are going to take home for today? One, burns injuries should not be managed by one specialty. The plastic surgeon, if you have a plastic surgeon in a center, the person can be at the head of the team, but it's a multidisciplinary treatment. And fluid administration is very much essential in the management of you must give adequate fluid, but you don't overload these patients. Then for the future trends, we are thinking that when you modulate cytokines, the effect of cytokines, that bones injuries may also be modulated, and you may achieve a better outcome. But whatever you do, bones injury is still the winner. Because like I mentioned at the beginning, bones gives you a sign that you have been visited. And once you have visited, there is a telltale sign that this patient has had bones. So prevention is always better than cure in bones. And bones is not a cheap thing, it's a very expensive treatment, and you need to prevent bones if possible. And we need to spread awareness in a society. There are bones that are really preventable, like in societies where gas is stored, petroleum products are stored in houses, people can be discouraged from doing that. Then in places where people move about with tea, when they're drinking, instead of sitting down to drink it, they move about with it, they come up with equipment, cases, especially scalp bones. A lot of education is necessary in the prevention of bones. But for the treatment, it's a multidisciplinary, and this must be emphasized. But unfortunately, in our system, because of litigation, a lot of persons are afraid to take up cases or even to join in a management of cases because they're afraid that that patient may sue the doctor eventually, and you'll be joined into that. And because of that, medical practice is really suffering because of this fear. And we do what we call defensive practice in most of the time. So this should be disemphasized, especially in bones, because bones is a multidisciplinary treatment. Yeah, whatever you do, you cannot do alone. You must bring other specialties into bones treatments. Thank you very much.
Thank you so much for the excellent presentation, Dr. Agu. And I think this is a good time for us to gather some thoughts, questions, concerns amongst the attendees today. And why don't I go ahead and start off with one of my own. So this one's regarding the logistics of burn management in your practice and the facility in which you practice. More specifically, how are burn victims triaged, referred, and transferred in the region of your practice to get them to experts like yourself and with facilities necessary to take care of these awful injuries?
Like I mentioned before, in the place where I'm practicing now, in the place where I practiced before, most people will want to manage the bones by this. Most private hospitals want to manage everything by them, even when they don't have the necessary specialties. But here, when we have difficult bones, if we have difficult bones, we activate what we call life savings. They activate life savings. And this life savings, once you call life savings, somebody in Riyadh will call somebody anywhere in the country where there's a vacancy, if this patient requires ICU admission, that hospital will be contacted and they will ask you to move. If it is necessary to move the patient with a helicopter, they will move the patient with a helicopter, ambulance. So that is what bonds actually deserves. Then for this place, we also have fax system. In all the hospitals where there are no specialists that handle bonds, around this place, there are 3 major hospitals in town where I am, in Half-Barton. Then when there are cases, and this is, my own hospital is the only hospital that has a lot of, that has a consultant plastic surgeon. So when they have these bonds cases, they have a fax system. And this fax system are automatic. They'll just fax message to us. I would say, bring this ICU space. And if there's no ICU, we activate the life savings. For major bonds, we just activate the life savings. You'll be surprised. Within some minutes, the patient is off, and off by helicopter, off by a very good ambulance to wherever you are transferring the patient. And as the patient is transferred, there's also attention to the patient's matter. The treatment is continued along the highway. So, but in my country, we have you have a scarcity of some of these things. They're not really fully developed. These emergency systems are not really fully developed. And then the bond centers, the established bond centers are also scarce. So most of the time, people try to manage. That's why this kind of teaching is important, because it gives you a little detail of what you can actually do in that center where you don't have those facilities. You can begin to do something until help comes.
Okay, thank you. I appreciate that. I have one other quick question, and then open it up to the audience. Are there any examples of which you are aware of the effective use of telemedicine for the diagnosis and treatment of burn victims in the region of your practice or elsewhere amongst your burn specialist colleagues?
Yeah. In the place where I'm practicing now, we have that in place. We have telemedicine in place. You can actually, there are facilities now that you can actually examine this burns wound. And if there are things you want the patients to do, you can listen to the heart sounds with a stethoscope that is linked to the IT, and then you can actually listen to somebody's heart and listen to abdominal sound in telemedicine. So we have a fully developed telemedicine that, although it is still evolving in this environment.
Right. Thank you. Thank you for that. So, to all of you, any other questions, comments?
There is a question in the chat from Henry, and Henry says, question, explain the role of beta blockers and hydrocortisone in the treatment of burns.
Yeah, where I mentioned hydrocortisone, when you get into difficult resuscitation, if you go through that slide, you find out when you are confronted with difficult situations, that is when you get into hydrocortisone, and also the use of beta blockers. It's not for everyday management of burns. But when you get into difficult situations, you have done everything that you're supposed to do, and you have a liguria, you've done everything that you're supposed to do, the patient is not doing well. That is a difficult situation. And in the management of burns in this place, we make use of the albumin is very much available. We have the 20%, we have the 5%, very much available. And in the kingdom here, treatment is completely free for every person. So the problem of not reaching these materials or this access to this material is not there. There are no health insurance here for citizens. And once you come in, the treatment is begun, and these facilities are there. The albumin is there. You do a daily check of CDC chemistry, and you monitor this patient, and you find out that most of the time you achieve results, because these monitors, this monitoring that you are doing are the things that you require to give these patients the optimal that the patient requires for speedy recovery.
Another question in the chat from Ken Obi is, he says, thank you for your beautiful presentation. Please, can you kindly elaborate on the use of a finger in ascertaining compartment syndrome? Thanks.
No, I actually was not talking about compartment syndrome when I talked of finger palpation. For compartment syndrome, you need to use a manometer to measure the compartment syndrome. But there are also signs. We talk about the 6 P's of compartment syndrome: the pain, the paresthesia, the pulselessness, and so on. Those 6 P's will guide you in knowing when you have a compartment syndrome. I was talking about finger palpation when you have a tense subcutaneous tissue. Edematous tense subcutaneous tissue. And you will find out that when you take these patients to the theater and you make a cut, the subcutaneous tissue just explodes like a balloon. And without this fasciotomy, you'll find out that you may have extensive necrosis, which you may find difficult. You may end up amputating that limb if care is not taken. So that is why, and by experience, when you palpate the bones wound, both electrical and flame bones, if you palpate, you should be able to know that this is a normal skin. This skin is under tension. And if you allow that, you may end up having extensive necrosis, which may be very difficult and embarrassing to continue to treat.
Another question in the chat from
Yes.
Ahmed Mirgani says, indications of antibiotics in burn, please recent guidelines.
Yeah, the guideline is that burns, normally we de-emphasize the use of antibiotics in burns. Because what we do in this place, we start, unless the burns is heavily contaminated. Occasionally people come with burns injuries which has been contaminated with herbs, with dirty, that treated by native doctors in the villages, and before they're transferred. Even that day that the burns occurred, they might have poured all kinds of things onto the burns. And when you have that potential infection of the burns, it's only natural that this is a contaminated wound and you need to do a prophylactic antibiotics. But for burns generally, we de-emphasize the use of prophylactic antibiotics. If you start the local dressing of burns wounds and you dress the first day, usually here, in my own burns practice, I try to dress daily for the first few days. First few days, 2 days, 3 days, dress daily. Then after that, you can now do alternate day dressing or every 3-day dressing. And like I mentioned, like I emphasized, it has to be a closed dressing so that there will be, you minimize moisture loss. Like I said, every dry wound is a dead wound. Once you have a dry wound, the epithelial cells refuse to migrate and they'll stop migrating. And when they see a heel, they do not climb heels. When you have granulation tissue that has formed the heel, they will not climb the heels. So when you have this scenario, you need to do the needful. When you have heavily contaminated, you need to. But for burns that you rescued and wrapped up the clean, you apply the necessary first aid, you don't need to. So when you dress the burns wound for some days, then you may need to now reassess. If there are areas that infection are cropping up, then you may need to use, you may not actually need an antibiotics. You may just use something like Savacel or any saver containing something like Acticoat and there's one in Nigeria, I've forgotten the name now. You can use, or actually use that. They are safer containing substances. They'll help you to control the infection. So it's not every time that you start an antibiotic, unless there's a clear indication for antibiotics use. You don't need to start an antibiotics.
We have a comment again from Ken saying, thank you. Please, is there any way of identifying a suicidal burn in a burnt patient? And how should it be documented?
Yeah, we had a mortality of a burns case recently in this place. A person is a non-Saudi who actually came and he actually lit himself. He poured this on himself and got himself burnt. So when you have that kind of scenario, there will be witnesses, and you still go ahead and just treat the patient as you treat any other burns. Then in that case, subsequently, you must bring a psychologist, clinical psychologist, to discuss with this patient, or bring a psychiatrist to really find out what the mental state of this patient is before you continue. You must have to do a consult to a psychiatrist or a clinical psychologist.
Great, thank you. We are coming up on a 5-minute mark, so I definitely do want to keep it open to anybody else to ask any questions.
While awaiting, go ahead.
Sorry. Oh, I just got a question, Dr. Gu. At your hospital, what's the rate of resistance to the antibiotics that you give? I would imagine it's a problem. It'd be a problem here. I just wanted to see what the pulse is at your facility.
I didn't get a question. Can you?
Sure. I just wanted to know, is there a big problem
Yes.
when you do have an infection, you have to use antibiotics? Is there a lot of resistance, antibiotic resistance there for the organisms that you're treating?
Yeah, in this place, there is an antibiotic policy. They don't just juggle antibiotics, they just recommend any antibiotics you have. There's an antibiotics policy. And these drugs are stocked, and you don't need to use them. There are checks and balances. There are papers you need to fill. So there are papers you need to fill that you want to give this antibiotic, and it must be indicated. If it is not indicated, the pharmacist will call your attention to that is it really necessary for you to give this? So there are checks and balances in antibiotics. Like I mentioned before, antibiotics is not really very necessary for burns. But if you have any reason to give it, you have to follow the antibiotic policy of the environment where you're practicing. Then if there are obvious infections for those cases that are coming from the villages or common mismanaged cases by native doctors and so on, these are the ones you take a wound swab, and based on your microscopic culture sensitivity, you place the patient on the appropriate antibiotics. But actually in burns, I have found out that in burns, you can actually control the infection by non-use of antibiotics, by just using things like Cell, Acticoat, and those safer containers. Those areas that those infections are coming to, you go there and attack with this. They work most of the time. I rarely use antibiotics for this burns case, because here they come clean. And once they come, if you notice any sign of infection on any part of the burns wound, then you can start a safer cell dressing there. And you find out that I think the infection clears up, the burns will continue to progress in normal healing.
Thank you. We have another question in the chat. I just want to get these in quickly. Azuma asked, or first said, thank you for the presentation. Please, at what point in burns treatment do we consider skin grafting?
Yeah, most of the time, deep burns, especially third-degree burns, are where you consider skin grafting. Then occasionally people mismanage second-degree, especially deep second-degree burns, and then convert them to third-degree burns by what they apply, allowing infection to convert such deep dermal burns into burns that, then if also you find out that it is better to grab this patient, by your own assessment, you will know this patient requires skin graft. That is why you don't just keep the patient in ward and disappear for 1 week. You must monitor that patient and monitor the burns wound, daily dressing or alternate day dressing. And you need to see this burn and know when to take action, because that is the most important. When do you intervene and do a skin graft? And now with electrical dermatome, you can actually harvest skin from the side of the burns wound and just use it to cover the wound also. So it makes this quite simple. So, but you need to really assess when you need to intervene and skin graft by constantly monitoring that burns wound.
And then one last question in the chat from Azija Godwin says, when do you think that rehabilitation should start in burn patients?
Rehabilitation?
Yes.
Yeah, the rehabilitation should start as the patient comes in with, like I said, burns is a winner. And burns is a winner. It always wins. So when you have burns, any burns will leave a telltale sign. apart from the first degree burns, which may heal without a scar. But if you look at that burns, even first degree, you may start seeing some sign that this person has had burns in the past. So burns is always a winner. So you must intervene because there's so many things involved in burns. You can have cosmetic issues, when burns of the face, you can have contractures, you can have morbidity that will overwhelm that patient. And money is not easily readily available, and the health insurance is, you don't have a universal coverage in so many countries. These patients suffer, they suffer so much. So it's better to prevent and it's better to intervene early so they can prevent some of the complications. Like when you have burns of the perineum and the axilla, you need to abduct, just simple abduction, just spread your hands like this, and then spread the legs, and then dress the fingers separately. You prevent creeping and you prevent artificial syndactyly or acquired syndactyly. These things are preventable. And then for the metasternal contractures, you just put a pillow behind the person's neck and you prevent a metasternal contracture. So many things, very little things, POP that you just use and modify. And then if there's a need for consult early. If you need a psychiatrist, consult a psychiatrist early. If you need a gastroenterologist, consult early. Consult the physician. Don't treat burns alone by yourself, and I feel that you will achieve results. You can't get an expert in burns because there are so many other specialties that are involved. You need to consult so that you achieve a good result.
Thank you. Before
Thank you
everybody
again,
heads
Dr.
out,
Okay.
go ahead, Dr. Pecchia.
Yeah, I wanted to thank Dr. Agu so much for sharing this with us. It was absolutely tremendous talk. I want to thank Alexa for her great work in setting this up and technically and in the flow of the session. Thank you again for that, and the global offsite care team. Thanks again to all of you for attending. We look forward to seeing you again here next week. Do keep in mind, think about presenting on one of your favorite topics. We would love to take a look at what you may have to offer for us in the future. And with that, Alexa, you want to go ahead and close for us?
Yes, thank you, everybody. Thank you, Dr. Agu, again. If you are interested in presenting, feel free to reach out. I can put my email directly into the chat. I can keep the room open for a bit if there's any more discussion. Otherwise, I wish you all a great rest of your day.
Thank you.
Stay well.
Thank you.
Thank you.
Dr.
Hey,
Agu, with the strict policies of stewardship for the antibiotics, do you see a lot of MRSA, for instance, or do you see a lot of other microbial resistance? Is it working? Are those strict policies working?
Asking me whether the policy is working?
Yeah, are they working to prevent microbial resistance to antibiotics?
No. It cannot.
No.
It cannot.
Okay. So you're no different than here. We have a big problem in the country. Okay.
Okay.
Thank you so much. What a wonderful
Thank
talk.
you.
I really enjoyed it.
Yeah, thank you very much. I appreciate it.
Yeah, I'm just wondering if any of you guys are still here.